Hello everyone, this is Craig Fitch with OCULUS. Welcome to another webinar. From OCULUS, we certainly thank you for attending this webinar, Understanding Evaluation-Based Tomography and its Use in Refractive Screening. Our speaker is Dr. Michael Belin. He is a professor of ophthalmology and vision science at the University of Arizona, Tucson, and past president of the Cornell Society and currently vice president of international development. He's the incoming chair of the American University Professor of Ophthalmology Fellowship Review Committee and a recipient of the American Academy of Ophthalmology's Honor Award, Senior Honor Award, and Lifetime Achievement Award. Ladies and gentlemen, if you have any questions throughout this webinar, please use the question box at the right of your screen. There will be an opportunity at the end of the webinar to answer your questions. Without further delay, please welcome Dr. Michael Belin.
Thank you. I'd like to welcome all of you who are in attendance. We're going to be covering a little bit about the basics, actually a fair amount of the basics of elevation tomography, and then go into the Belin Ambrosio display, particularly how it's utilized in refractive surgery, a little bit about how it was developed, and when you look at it, what are you actually seeing? So let's start off. So I think you need to return the control to me. Okay. Well, first of all, what's the difference between elevation-based tomography and Placido-based topography? And is there still a need for Placido imaging? Well, curvature, and curvature is produced from a Scheimpflug, but curvature is produced from a Placido system, and the problem with curvature is that it doesn't really depict shape. Now, I'm big on analogies, and curvature is analogous to measuring the spectacle lens power. And chances are, if I gave any of you a pair of glasses and said, okay, tell me what these glasses are, the first thing you would do is you put them in a lensometer and you would read a power. And that power is extremely accurate. If I gave it to a number of you, you probably would get the same within an eighth of a diopter. It's accurate, but it tells you really nothing about the actual shape of the lens. We all know that multiple spectacle lenses, as you can see on the bottom right, can have different shapes but have the same power. So I put any of these different shapes in a lensometer, and I'll get the exact same reading. Again, the reading is accurate, but it tells us nothing about shape. And constantly you hear people look at curvature maps and start discussing shape, but you really can't. Curvature is analogous to, again, lens power. And it doesn't really give you a shape analysis. Additionally, the same shape can have different curvature readings or different power readings. We all know that if you take a lens and you alter its orientation, in this case tilt, you'll actually get a different power reading. And it's the exact same thing with curvature measurements of a cornea. The exact same shape cornea can have two different curvature readings depending on its orientation. Now, elevation is more analogous to if I gave that same pair of spectacles to a person who makes glasses. What they would do is they would take a Geneva lens clock. If I asked them to duplicate it exactly, they would read the shape of the front, the shape of the back, they would read the thickness. Now, without ever actually putting it in a lensometer, they can duplicate that lens exactly. So it doesn't directly measure power, but it gives you an accurate representation of the true shape of the lens. And if the shape of the lens is known, power can then be calculated. Now, the problem with curvature, I'm going to say this again later, that this is a problem with curvature. It's the same limitation whether the curvature is produced from Placido, OCT, or Scheimpflug. It's a limitation of curvature. The problem with Placido is that's what it measures. It doesn't have other options. In actuality, it measures slope. But curvature-based topography treats the eye as if it's a Gulf strand reduced eye. What do we mean by that? Well, it assumes that the line of sight, the measurement axis, the center of the cornea all line up like a perfect Gulf strand reduced eye. And we know that's actually not the normal anatomical case. Normal eyes do not behave like a Gulf strand reduced eye. The line of sight, the apex, and the normal to the cornea surface are actually all different. And we know that from pediatrics, that's angle kappa. Well, what is the implication of that? Well, these are two different corneas of identical shape. But like the slide I showed you earlier, where we had a spectacle lens that we tilted slightly and it changed the power, though the shape was identical, these are two different corneas that are identical in shape. The one on your left behaves like a Gulf strand reduced eye. It's a zero angle kappa. The one on your right has an angle kappa. So the line of sight, the corneal apex, and the normal to the surface are different. And what happens if you do a curvature map on these two identically shaped corneas? You get totally different maps. Now, the map on the left looks like a perfect symmetric bow tie. The map on the right, if I showed it to 99% of the people, they would say this is an eye with significant inferior steeply and keratoconus. These two maps were actually produced from a perfectly astigmatic test object, exactly the same object. The one on the left had 0 degrees angle kappa. The one on the right had 5 degrees. 5 degrees is the upper limit of physiologic normal. That map on your right is a normal cornea. That's the limitation of curvature. These two dramatically different maps, dramatically different curvature maps, actually come from the exact same shape cornea. So again, curvature does not imply shape. This is a nice animation by Renzo Mattoli, who is an Italian optical PhD. And what it shows you is as that reference axis or that point of orientation changes, the curvature map changes dramatically. The one on your left and the one on the right is axial and tangential, and you'll see again that the maps change dramatically. This is basically taking a cornea with 0 degree angle kappa and increasing it. And what you'll see again is that the curvature maps change dramatically. Now, as I said already, elevation-derived curvature has the same limitations as Placido-derived curvature, the same limitation as OCT-derived curvature. It's a limitation of curvature. And that is why I look at elevations. I really rarely look at a curvature map. Elevation represents true shape. Within physiologic range, it's independent of axis, orientation, or positioning. Now, that doesn't mean the map stays the same. What it means is that the appearance of the map looks as if it was just tilted. And the example I always give would be kind of an American football. If I hold a football and I point the laces at you, and then I move the tips up and down or left and right, it still looks like a football, but the laces move. If I do the same thing in a curvature map, it changes the appearance completely. The other advantage of elevation is that it can derive curvature. Curvature is the second derivative of elevation. You cannot, however, start with curvature and produce an elevation map without making assumptions. And for those of you who remember your calculus, curvature is a derivative. That's a unique solution. It's actually the second derivative of elevation. So if you have elevation, you can produce a unique curvature map. But for curvature to produce an elevation map, it's an integral, and there are multiple solutions. So you might say to yourself, well, I have a Placido system that produces an elevation map. Well, it does that by assuming certain shapes, and it assumes that what you're measuring follows spherocylindrical corneas. What that means clinically is that it does a reasonable job in a normal eye, and it does a terrible job in an abnormal eye. And when you really need the information is in the abnormal eyes. So this is an example of that. This is something, if you look at the data, you'll see how old this is. This is some work I did now almost 20 years ago. The picture on the upper left is it's an anterior elevation map of the cadaver cornea. And basically, it's spherical. It's an irregular surface because it's cadaver cornea, but it's pretty much spherical. And what I did is I just did a small ablation, and then I just I tilted it, I rotated it slightly. And you'll see in the picture on the upper right, the ablation is down and to the left. Then I moved the cornea up a little bit. You can see the ablation moves up. And then picture on the lower left, you'll see I just moved it back down, but a little bit more to the right. It wouldn't be difficult to convince you that these three maps with the post-ablation are the same cornea, just that they've been changed in orientation. Again, the football with the laces, and all I'm doing is moving the laces. But it still looks like a football. If I do the exact same thing with curvature, this is what happens. Okay? And it would be hard-pressed for the upper right and the lower right for me to tell you those actually represent the same cornea. So again, that's what happens with curvature. Curvature does not depict shape, and it's not a unique property of the cornea. Now, a lot of times you'll hear people say, well, that's because it's axial or sagittal, but if you do instantaneous or tangential, it's a much better analysis of shape. And this is the tangential or instantaneous curvature. And again, if you look at the upper right and lower right, you would be hard-pressed to, again, say this represents the same cornea. And again, go back and compare that to the elevation map, which again, the analogy is that football where I'm just moving the laces up, down, left, and right. So again, if you have elevation, you can derive curvature. If you can measure the anterior elevation and the posterior elevation, then you can also derive a full corneal thickness map. Corneal thickness is just the spatial difference between the anterior and posterior surfaces. So again, if I can measure the anterior surface, I can measure the posterior surface and elevation, I can produce the elevation maps, I can produce the curvature maps. But again, if I'm accurate on the anterior and posterior surface, I can also produce a full corneal thickness map. And clearly, systems that are Placido-based, not only can they not measure a posterior surface, but they clearly cannot generate a corneal thickness map. And again, as already alluded to, curvature cannot produce posterior data, cannot produce corneal thickness, but it really, I would take it with a huge grain of salt, any anterior elevation data that a curvature system attempts to generate. Because the only way it can do that is by assuming shape constants. And again, what it assumes is spherocylindrical optics. So do you still need to use a Placido topographer? I have not personally used a Placido topographer in probably 12 plus years. I hear a lot of people say, well, you know, I have a Scheimpflug, I have a Pentacam, but I still like looking at the Placido curvature maps. Well, that doesn't make a whole lot of sense because the curvature maps, if you want to look at them from a Scheimpflug, are clinically identical to the curvature maps on a Placido with a few provisos. One is Placidos have very limited coverage, and that's because they are reflective. So you'll rarely ever get as much corneal coverage as you'll see on a Pentacam. And here you'll see, this is just one example, the curvature map on your left from a Placido system, the curvature map on your right from the Pentacam. And what you will see, and I'm going to flip through these quickly, is that clinically the information you will see is clinically identical, except again you will see a lot more dropout on the Placido and less coverage than you'll get on a Scheimpflug. And the reason for that is twofold. One is a Placido is reflective, so you get a lot of dropout if there's tear film abnormalities. And actually, Oculus put that to good use with their keratograph by developing a way actually to analyze a dry eye patient. And also what you'll notice is that you'll get much more coverage with the Scheimpflug. And actually the pictures on the right, I've curtailed to only 9 millimeters. You can actually get beyond that. And the reason for that on a Placido is not only is it tear film abnormalities, but anatomically you can't bounce light off the periphery, corneal periphery, and get it back to the camera. So it's optically and anatomically limited to how much corneal coverage. Let's flip some of these. And again, what you'll see is that clinically the information is identical. You notice, again, a lot more dropout on the Placido system. And again, you'll see a much smoother image on the Scheimpflug. But again, the clinical information looks identical. You can see a significant dropout in poor coverage on the Placido in the left eye. And again, these are the same patients taken within minutes of each other. And you can see what better coverage you'll get with the Pentacam. Again, clinically the same information. Again, you'll see the poor coverage that you'll get compared to the Pentacam. So again, I personally don't really see the value of doing a Placido curvature map when the curvature maps, if anything, give you better coverage and more information from the Pentacam. And then this is the same thing here, but now rather than comparing it to a Humphrey, this is the Magellan. And here the comparison is up and down as opposed to left and right. And again, you'll notice is that the coverage will be greater, but that the clinical information you will get will be effectively the same. Again, you can see that here. And again, if you look at the picture on the left, you get the exact same asymmetric bow tie, except a much better coverage with the Pentacam than you'll get on the Magellan. Now, I've said a few times, clinically identical. And the reason I said that is that they will never be absolutely identical because they actually measure slightly different things. As I said, a Placido is reflective, and it reflects off the tear film. A Pentacam uses a Scheimpflug, does an optical cross-section, so it actually measures the first optical surface, which is the first actually non-transparent optical surface, and that's actually the epithelium, or the anterior corneal surface. So they're slight difference. One is measuring or reflecting off the tear film. One is actually doing an optical cross-section, and is actually the anterior corneal surface. But clinically, as I showed you, they're effectively the same. Also, if you look at that little schematic on the upper right, that is about the area of coverage that you will get on a Placido system, which actually represents, at best, about 50% of the corneal surface. So, long introduction, but do you still need to use a Placido topographer other than looking at tear film breakup time, which, but as far as looking at corneal shape, screening for refractive surgery, my answer is no. The curvature maps generated, and again, I actually don't look at the curvature maps. And when we get into the Belin Ambrosio display, that's a complete elevation-based analysis. So let's start with our second introduction now and talk a little bit more about Scheimpflug imaging. This is a single Scheimpflug image. This is the optical cross-section. As you know, the Pentacam works by taking, very similar to how a CT scan works, with a series of X-rays and then reconstructs it in 3 dimensions. The Pentacam takes a series of optical cross-section using Scheimpflug imaging. Scheimpflug imaging is a way of increasing the depth of field. And here you can see that we have the anterior lens, the posterior lens, the anterior cornea, and the posterior cornea in fair clarity. Again, so the Scheimpflug technology is a way of increasing depth of field. And what you'll see again in red is the edge detection program. So it's identifying the anterior corneal surface and the posterior corneal surface. And as I mentioned before, if you can measure the anterior corneal surface and the posterior corneal surface, you can then compute corneal thickness. What I do want you to notice is the red is the edge detection software, and you notice that it goes out almost out to the limbus. And you can compare that to that schematic I showed you earlier with the Placido, which is only really covering about 50% of the cornea. It also measures the anterior lens and the posterior lens. And if you can measure the anterior lens surface and the posterior cornea, you can measure the anterior chamber depth also. This is an eye that was dilated widely, so you really don't see much of the iris. And also, it measures lens transmissibility. So again, this is just a single optical cross-section, and the Scheimpflug uses, the Panacan uses either 25 or 50. Most people default to the 25 scans, and then it recreates in 3 dimensions by actually utilizing like a CT to form a 3-dimensional image of the anterior segment. So if we can compare the Panacan versus Placido-based imaging, the Panacan gives us the anterior and posterior surfaces. Placido is anterior only, and only about 50% of the anterior surface. Scheimpflug gives us a full pachymetric map. There's no measurement of corneal thickness thinning. The Panacan is capable, though it's rarely capable of limbal to limbal coverage, but I would say that on routine usage, it probably goes out to 10 millimeters. Partly because it's hard to get the patient to open the eyes beyond that. But if you really hold someone's eyes open, and we do this when we have peripheral disease, you can get, and if you remember the picture I just showed you, that Scheimpflug image, that was pretty much limbal to limbal coverage. And with the Placido, coverage is limited to less than 9, and actually rarely ever even gets close to 9. And again, because Placido is curvature-based, there's a high incidence of false positives, as I showed you in some of those early slides, where that same astigmatic test object had totally different curvature maps, one looking highly suspicious for keratoconus when it was a normal astigmatic surface. And elevation is not or less susceptible to those false positives. So let's now give you some examples of the value of elevation tomography. And when we're screening patients for refractive surgery, what we're really looking for is to screen patients who either have occult ectatic disease, I call subclinical ectatic disease, or have maps that are suspicious. And what are the earliest signs of ectatic disease? So what is keratoconus? If you go to any textbook, what you'll see over and over again are just 2 words repeatedly. It's a non-inflammatory progressive corneal steepening disorder. So we hear the word steepening, and the other thing that you hear constantly is a non-inflammatory progressive corneal thinning disorder. And whoever definition you use, those 2 words, steepening and thinning, are constantly used. So let's talk about thinning. Okay? But again, I want you to keep in mind it's thinning and steepening. So how can the cornea thin? Well, there's only a couple ways a cornea can thin. For the cornea to thin, one of 2 things must happen. The anterior surface can move back. That would cause corneal thinning. It, however, causes flattening, which again is not what we see in keratoconus. That could be in an ulcer, that can be in a melt, but again, if ectatic disease is a thinning and a steepening disorder, we know that cannot happen. Or the posterior surface can move forward. Now, I'll talk about this later, and that's actually what is almost the earliest signs of ectatic disease, but that would cause thinning, but doesn't cause steepening. So there's got to be really a third option. Okay? And what is that third possibility? And this is a very simple concept that I think really stresses the importance of being able to measure the anterior, but particularly the posterior surfaces. Both surfaces can become ectatic, but the only way you can get thinning and steepening is if the posterior surface moves more. If the anterior surface moved more than the posterior surface, you would get thickening. So again, I just want you to think about that for a second, because we always talk about what's the importance of the posterior surface, and I've always said that to me it's a more sensitive as well as an early indicator of ectatic disease. But to get steepening and thinning, the only way you can get a steepening and a thinning is if the posterior surface moves more than the anterior surface. Again, it's just what I said. The only way to get thinning and anterior steepening is for the posterior surface to move more. And not only that, but posterior ectasia will often precede any changes on the anterior surface. And we call that, and we've published this a few years back, subclinical keratoconus. If we look at the map on the upper left, what you will see, again, I'm just talking about the four composite on the upper left. The first map, upper left, is a curvature map, which is normal. The upper right is an elevation map, which is normal. But if we look on the lower right, and I know I haven't explained these maps yet, that's a posterior ectasia. This is a patient with thinning and posterior ectasia, but a normal anterior surface. So it's not a normal cornea, but it's a patient with normal vision. Now, granted, if you probably tested them on very sensitive contrast sensitivity, I'm sure they have some aberrations. But in general, this is an asymptomatic individual with an ectatic cornea limited to the posterior surface. If we look at the four map on the upper right, we see a similar condition, a completely normal anterior surface. Curvature on the upper left, elevation on the upper right, completely normal, but you'll notice an even more prominent posterior ectasia on the back surface, which is the lower right. And if you look at the corneal thickness map on the lower left, you'll notice that the thinnest point is displaced to the area of the posterior ectasia. So you have an ectasia on the back surface that causes thinning as we expect, and you'll see that that posterior ectasia corresponds to where the thinning point has been displaced, but a completely normal anterior surface. These upper two are subclinical keratoconus. Now, if you look at the lower map, here we have more advanced disease. And there you'll see we have ectasia on the anterior surface, ectasia on the posterior surface, and a big displacement on the thinnest point. But again, if you look at the anterior elevation, which is the upper right, and the posterior elevation, the lower right, the colors and scales are identical. You see that the posterior ectasia is greater in magnitude than the anterior ectasia. And again, I've never seen a case where that's not the case. The posterior cornea has a greater degree of ectasia, and that causes the thinning. So this is markedly advanced keratoconus. We have changes on every surface, but again, the posterior cornea is more ectatic than the anterior cornea. So how do we diagnose keratoconus? We look at elevation changes on both the anterior and posterior surface. You look at corneal thinning. You look for displacement of the thinnest point. Also, what we haven't discussed, you look at, here I have pachymetric asymmetry. Look at asymmetry in all points between the right and left eyes. And something I'll talk about later, we also look at an abnormal pachymetric progression. And I'll discuss that later. But that's the rate of change of corneal thinning from the limbus to the thinnest point. So I started talking about elevation without really describing how we actually display the elevation. So we use the term elevation actually incorrectly. You never really see a true elevation map. The Scheimpflug system, just remember the picture I showed you with the edge detection, locates points in space via edge detection. Placido systems that I mentioned measure slope. They actually don't measure curvature. Scheimpflugs actually don't measure elevation. They locate points in space. Both systems process the data to make it clinically useful. Okay. This is actually the raw elevation data. So if you were to take and just put where the points in space were, this is what we call raw elevation maps. And you're never shown these. The reason you're never shown them is that you can't look at raw elevation data and determine what's normal and what's abnormal. The map on your left came from a normal eye. The map in the middle came from a moderately advanced keratoconus. And the map on the right was advanced keratoconus. And the reason for that, if you think about it, even if you had advanced keratoconus, if I was to lay that person flat on their back and had them look up to the ceiling, the apex of the cornea is still higher than the cone. So the elevation maps don't convey, raw elevation maps don't convey information in an intuitive fashion in the way you can look at it and make a quick analysis. So what we do is we have to take that information and put it into a clinically useful method. But I want you to remember is that to the computer's looking at the raw elevation data. It doesn't matter what we do with it or how we display it. The computer's just using the raw elevation data. The most common method to display it is to compare it against a reference surface. And what that reference surface does actually, it amplifies the changes. And the most commonly used reference surface is a best fit sphere. I want to stress that a reference surface is just there to allow us to make a qualitative examination. The reference surface does not affect accuracy. Okay? The computer uses the raw elevation data. We pick a reference surface to take that data which is not intuitive to us and make it so that we can look at it and understand it. And the most common used shape is a best fit sphere. And if we look at an astigmatic shape, this is how it would look against a best fit sphere. If you had a perfect astigmat, the flat meridian, which is shown in blue, would be raised above the best fit sphere because, again, it's flat and doesn't, quote, curve as much. And the steep meridian in red would fall below the best fit sphere. So you get what looks very similar to the astigmatic bow tie pattern that you use to a Placido, except the color is the opposite because steep is negative and flat is positive. But that's a normal astigmatic pattern on a best fit sphere. Now, if we look at the picture on the left, that is a patient with pretty much pure astigmatism. And what you'll notice again is at the center, you have a reading of 0. That's because that's where the steep and flat meridian cross. And the flat meridian, which is roughly about 160 degrees, is positive, and the steep meridian, roughly 70 degrees, is negative. Now you'll see these numbers throughout. Again, 0 at the center, and it goes out to about 26 on the about a 3 o'clock position. Those numbers represent the separation of that meridian from the best fit sphere. The numbers themselves only tell you two things: how much astigmatism is present and how far you are from the apex. The further you go, the greater the separation is from the steep and flat meridian. The first thing you do when you look at a map is it's pattern recognition. So I looked at this astigmatic pattern, and it's a completely normal astigmatic pattern. The numbers then are secondary. The numbers just tell me how much astigmatism is present. Compare that to the picture on the right. It looks completely different. We call that a positive island of elevation. That is what we look for when we're screening for hepatic disease. I purposely chose these two maps because you notice the maximal positive number on the left is 26 and on the right it's 30. They're pretty close. The difference is not the numbers, the difference is the pattern. Left is a normal astigmatic pattern. Right is a very abnormal pattern. Again, we call it positive island of elevation. Well, I already described how we generate that astigmatic pattern. But why do we see this in an ectatic cornea? We call this a positive island surrounded by a sea of blue. And why do we see that pattern? Well, if we just take again, use an analogy and exaggerate, just take a cone, a pure cone. And if I was to say, okay, how would that cone look against a best fit sphere to that cone? This is what would happen. Notice that the top of the cone is truncated, corresponds exactly to what you see, and the tip of the cone is the highest point. And what you'll notice, I'll see if my mouse works. Try to avoid mouses on webinars. You notice that once we get right here, we go from positive to negative in a sharp transition. Notice that 0, which is the green, is just a thin circle here. And right when we go past there, we get negative. But notice the greatest negative is not in the far periphery, it's in the mid-periphery. And that's that deep sea of blue right over here. So this is the generation of that ectatic picture, a positive island of elevation surrounded by a sea of blue. Now, in truth, you'll almost never see a picture as pure as that, because as we know, most patients with keratoconus also have high astigmatism. So what we're looking for are those positive islands that have been superimposed on an astigmatic picture. Okay. Why do we use a best fit sphere? As I said, it doesn't affect accuracy. It's qualitative. It gives us the most intuitive, qualitative information. You can look at it and you can get a feel for what the shape of the cornea is. And real quickly, because we're getting late, these are comparisons of different reference surfaces. This is an ectatic cornea. The upper left is a sphere. You can see that positive island of elevation. The upper right is an ellipsoid. It masks it. The lower right is a fixed toric ellipsoid. You can see it, but it's not as easy to see as a sphere. And the lower right is a best fit toric ellipsoid. Again, it masks the cone. Same thing over here. What you'll see, I'll flip through these quickly, is just that if you're looking for a positive island of elevation, the sphere is just the easiest to look at. You'll see it the easiest. Here, all of them show it, but again, notice the magnitude is greatest on the best fit sphere. So that's why I recommend a best fit sphere. Again, I just find it the most intuitive surface to look at. But is it the best reference surface? Again, as I said before, the reference surface doesn't affect accuracy. It's there to improve visual inspection. The most common analogy, one that we're all used to, is looking at maps of the Earth. And when we use maps of the Earth, the reference surface is sea level. There's nothing magical about sea level except it's easy to understand. If I was to show you these 4 locations on the globe, New Orleans, Denver, Dead Sea, and Mount Everest, again, New Orleans is basically sea level 0. Denver is a mile-high city, so it's 5,000 feet. The Dead Sea is below 0. Mount Everest is roughly 29,000. None of you, if I told you and took off the name and said which one's Mount Everest, which one's New Orleans, which one's Denver, Dead Sea, none of you would get it wrong, because sea level is an easy-to-understand reference surface. It's clinically useful. I can look at the same area using the center of the Earth as a reference. And if I took the names off this graph and showed it to you, none of you would be able to tell New Orleans from Mount Everest from Denver to the Dead Sea, because while the center of the Earth is just as accurate, it's clinically not appropriate. To the computer, however, these 2 graphs are identical. The computer would look at this and the other one using sea level, and they would be identical. But for us, for a qualitative inspection, sea level makes sense. It's easy. It allows a quick analysis. Center of the Earth is not. Realize, however, that sea level is not a best fit sphere. It's not the average of all the lands in the oceans. It's, however, easy to understand and visually highlights the mountains. Well, what would happen if we did a map of the Earth using a best fit sphere? What would happen to Mount Everest? Well, if we actually did a best fit sphere as opposed to sea level, maps of the Earth, Mount Everest would go lower, because the best fit sphere would now average not only seas, but it would average in all the lands and all the mountains. So you would have a higher reference surface, and Mount Everest would actually appear lower. It would be accurate, but it would be higher to pick out the mountains. And what we're doing when we're looking for ectatic disease is we're looking for the mountains. So the question is, can we produce a reference surface that more closely mimics sea level? So this is what happens right now. This is supposed to look like an ectatic cornea with a best fit sphere. As you can see, like I showed you with the cone, the best fit sphere truncates the top of that ectatic region. This is using a best fit sphere. What we really would like is to somehow mimic sea level, because this is what it would look like with sea level. And it would allow that cone to even stick out more. So the question is, can we do something to allow the ectatic region to even be easier to see? And what we've done is we've taken the regular best fit sphere, and what we normally do when we do the best fit sphere, we compute all the information within the central 8 millimeters. And what we've done is we've come up with something called an enhanced reference surface. And what we've done is we've taken the same best fit sphere from the central 8, but we've eliminated a it's actually a variable 3.5 to 4 millimeter zone surrounding the thinnest point of the cornea. In other words, we remove the mounting. So what we're trying to do is take the best fit sphere above and get a shape that more closely mimics sea level below. Because what we want to be able to do is, again, make it easier to see the ectatic region. We want to take the picture on your upper left and convert it to one on the upper right. We also want to make sure that if we have a normal eye, that our enhanced reference surface doesn't make a normal eye abnormal. So we don't want to have an increase in false positives. So this is an example. The picture on your left is a very subtle early cone. And this is actually on the back surface. What you'll notice is an astigmatic pattern with a very early positive island right over here. And this is using the standard best fit sphere generated from the central 8 millimeters. This is the exact same cornea now with the enhanced reference surface. Notice how much easier it is to pick up that positive island. So again, it's like comparing sea level to a best fit sphere. This is a best fit sphere. This is sea level. This is Mount Everest. It's easier to see. This is another example. This is the anterior surface with the best fit sphere. This is the anterior surface with the enhanced reference surface, much easier to see. None of you would miss this, but again, with the enhanced surface, notice that it becomes even higher, 60 to 87. So again, the enhanced reference surface amplifies the ectatic regions. But just as important is it doesn't create false positives, because if you don't have mountains to begin with, when you remove that area, you don't significantly change the reference surface. And here on the upper left is the standard best fit sphere. The upper right is the enhanced, almost identical. The lower picture, again, almost identical. When we looked at a large series, I think up to 1,200, what we found was that the change going from the standard best fit to the enhanced in normal eyes was less than 2 microns, and in eyes with keratoconus on the anterior surface was roughly 20 microns, and that was highly statistically significant. On the posterior surface, the change going from the standard to the enhanced reference surface in normal eyes was less than 3, while it was roughly 40 microns on eyes with keratoconus. Graphically, that's what you can see here. The eyes in green, the normal eyes are in green, the abnormal eyes were in red, and these numbers represent the elevation change from the standard best fit sphere to the enhanced reference surface. So what we actually found out was, by looking at that change, how much elevation change we get going from the standard to the enhanced, we were able to selectively separate normal from abnormal corneas. And that led us to try to develop a map that combines that information with a lot of work done by Renato Ambrosio on pachymetry. And let's just go to the next picture. So this was the first, quote, Belin-Ambrosio display. And so I will use the map. So this is the anterior elevation using the standard best fit sphere. This is the anterior elevation with the enhanced reference surface. The dotted lines represent the pupil. The solid circular line represents that exclusion zone, what we've taken out to compute the best fit sphere. This represents the numerical difference, the change going from here to here. We probably, and I keep saying it, we haven't done it. I'm backing up a slide. It's this graph. And you probably should not show it to look like a map. It's not a map. It's that graph I showed you. We probably should just make it square. But it represents the numerical difference. Here, again, the back surface, notice you see an early ectasia becomes highly magnified using the enhanced reference surface. And here you can see, again, the change, which is highly significant. This is the corneal thickness map, and these are two pachymetric progression maps that I will describe shortly. So Renato's, the right half has to do with all pachymetric data, and these are Renato's pachymetric progressions. And what Renato says is, I'll say it the way he does it, and I'll kind of make it a little bit easier. He says that an eye with ectasia or keratoconus, if you start at the thinnest point and move to the periphery, it thickens more rapidly. So the rate of change is greater, which is correct. It's a little bit more intuitive if you just kind of say, if you start at the limbus, which in even eyes with keratoconus, the limbus tends to be fairly normal in thickness, and you move to the thinnest point, it thins rapidly. So there's a greater rate of change. And I'm just going to concentrate on the lower graph here because it's easiest to understand, really the only one that I routinely look at. That's called a percentage thickness increase. And there were three lines, upper, lower, and middle. You can't see, let's go over here because this one's being hidden by the red. So this is a 95% confidence interval of a normal eye. This is the mean. So it's mean and 95% confidence interval. This represents the rate of change. So these two corneas have identical central ultrasound readings. They have the exact same value, but they're dramatically different. If we look at this eye, you'll notice the tracing is right down the middle. So it's a normal change, rate of change from the thinnest point to the limbus. If we look at this eye, you'll notice it's completely outside of this range. And if you're down below, that means an increased rate of change. This is highly abnormal. Even though these two eyes would give you the same ultrasound reading, this eye is highly indicative or suggestive of ectatic disease. This is normal. And that's the value of looking at pachymetric progression versus just looking at a single data point. The second release of the Belin-Ambrosio display added some statistical analysis. So I already told you that that change from going from the best fit sphere to the enhanced, we called it DF, which is just the front surface. The change going from the back surface, we called DB, the back surface. The pachymetric progression, we call P. The actual thinnest point, the value of the thinnest point, we call DT. And the displacement of the thinnest point was DY. We added all these parameters into a regression analysis. So it's not just an average of all these. It was put in the regression analysis to determine a final value. So again, this is the front surface, the back surface, the pachymetric progression, the thickness, and the displacement of the thinnest point. These numbers are reported as standard deviations. The regression analysis is really what's important, is the final number we call the final big D. This is the only number that has discriminatory value. This is just, again, if we think about 1.6 standard deviation from the norm, over 5% of all normal people will have that. The only value that has discriminatory potential is the final overall reading. Again, these also are not equally weighted. That's what a regression analysis does. So this was what that second release of the map looks like. This part looks the same, but we added those 5 parameters, and we added overall reading. The only part I'm going to highlight on this, because we're running short on time, is it's very important to look at this number right here. This number tells you the amount of corneal coverage that was analyzable. Remember I said we need our best fit sphere is computed from 8 millimeters. If you don't have 8 millimeters, then you don't have all the data necessary to compute both the standard best fit sphere and the enhanced reference surface. So this will turn yellow if you're less than 8 millimeters of coverage. It'll turn red if you're less than 7.5 millimeters of coverage. If you see a red box here, you need to repeat the image. Yellow, you can repeat it, but I've not seen a huge loss of clinical value on yellow. But when you get less than 7.5, you really want to repeat the image. The third release, which is the current release, added a number of new parameters. We went from 5 to actually 9 parameters in the regression analysis. We still only show you 5 parameters down. There wasn't room, but we actually have 9 parameters that we use in the regression analysis. We added elevation at the thinnest point, Kmax, a thing called ART, which is Ambrosio relational thickness. It's another pachymetric progression. The other thing that we did is we added a separate database for hyperopic patients, and we call it hyperopic. It's actually any axis that's positive, so that's mixed cell or hyperopia. We also gave you the option to turn off the colors on the individual parameters, but not the final number. The reason for that is just medical legal. Sometimes you can get an isolated red value here and have a completely normal final reading, and some people don't like seeing that in their chart. So the reason we added a hyperopic database is, again, hyperopes. We know hyperopes are different than myopes. They have flatter corneas, they have different anterior chambers, and it turns out that they actually have different elevation values, particularly on the posterior surface. And we're really running out of time. So these are just the graphs of each individual parameter to show you that no single parameter actually has adequate discriminatory potential. So you'll see these are ROC curves. You'll see, let's say, again, this is just thickness. This is a pretty poor performing. This is a very poor performing parameter. This is the location of the thinnest point. And again, you'll see that the final D, which is a regression analysis of 5, this is bad 2 release, performs much better than any single parameter. We added, again, front elevation at the thinnest, back elevation at the thinnest, Kmax. The only reason we added Kmax is you can see it's a pretty poor performing parameter. It's because it's what people are using in the cross-linking studies. And here's Ambrosio relational thickness, and this is the final D of version 3, which actually is a very good performing parameter. If we look at the difference between version 2 to version 3, this is version 2, this is version 3. For those of you who are used to looking at these, it is extremely difficult to get improvement once you get in this kind of area over here. This actually represents a very significant improvement in performance of version 3 versus version 2. So what were the improvements made to bad 3? We added, again, additional parameters of anterior at the thinnest, posterior at the thinnest, Kmax, and ART. We added new testing that also included a subpopulation of so-called unilateral keratoconus. So we did additional testing for our regression analysis. We also made the map, I think, easy to understand. We added all these little yellow triangles, which actually are drop-downs. So if you put your cursor over it and right-click, you'll actually get a drop-down that will explain what that parameter is. So this is what the new or the current looks like, and you'll see all these values here are reported as standard deviation. So even though we only show 5 here, this is in the regression analysis, this is in the regression analysis, this is, and that is. Okay. And again, this is just a close-up of all those yellow triangles. If you put your cursor on it and click, you'll get a drop-down that will explain what each parameter is. And this is an example of why we add the hyperopic database. So this is a hyperopic patient on the Belin Ambrosio 3, and you'll notice that it's completely normal. But if I were to run that same patient on the second version, notice we got a yellow warning here. Because again, this is using only a myopic database. So we call it normal. We probably should call it myopic, hyperopic. But if you have a patient where any axis is positive, you want to click on the hyperopic because it uses a different normative database. And again, we gave you the option to turn off the colors because of an example like this. We have a yellow warning here, but a completely normal map. If you want to, it can look like this. Finally, realize individual parameters do not have discriminatory. It's only the final D. You can have individual yellows and red, but an overall D, that's acceptable. You also need to look at other information, age, ablation depth, family history. Always look at symmetry between the two eyes. So again, the bad 3 allows for a high specificity and sensitivity. I don't feel additional testing with Placido is needed. You do need to use other information to make a final clinical decision, age, ablation depth, family history, stability, and always remember to compare both eyes. So putting it in perspective, my last slide here, this is some pre-publication work that we've submitted. I just want to kind of show you what this is. This is refractive screening. So when I'm screening, let's say I'm willing to accept a 95% confidence interval. So that would mean if I'm looking at 1,000 normal patients, here I'm going to accept 5% false positives. Here I'm only going to accept 2.5% false positives. And what would happen with each of these parameters? Well, for me to accept 95% of my normal populations, if I use minimal pachymetry in the screening, I would also include 38% of my cones. And what you'll notice here is some of these aren't bad, but Kmax, I would include 10%. And if you look at all these, but if you look at, again, what the final D is, you'll see it performs dramatically better than any single parameter. So a final D, if you're comfortable at a 95% confidence interval, it's 1.65. 1.88 is a 97.5%. But again, the purpose of this really is to show you that the final D performs better than any single parameter. And it's exactly at 6 o'clock, and that's my last slide. So for a few minutes, if anyone had questions.
Thank you very much, Dr. Belin. Yes, there is a couple of questions here that I'd like to go through. Is how do you make sure that if the patient has ABT or suspicious-looking curvature map on a pentacam is not keratoconus suspect? And if elevation map is normal,
ask that again.
How do you make sure?
Go ahead.
Yep. How do you make sure that if the patient has ABT or suspicious-looking curvature map on a pentacam, it is not keratoconus suspect?
I'm looking at the elevation maps. The elevation maps, remember that 20-year-old slide I showed you? The elevation maps will look like there's displacement, but the pattern will not be abnormal. And that's the problem with curvature. You get a patient with positive angle kappa, you'll have a suspicious-looking curvature map. But the elevation maps will look like they're displaced, but the pattern is normal.
And another question here before we wrap it up is, what parameters do you look at on the pentacam for keratoconus progression?
Very, very good question. One that's at the moment the biggest discussion point, and one that's going to be discussed heavily at the ESCRS. I look at changes on anterior elevation, posterior elevation, and corneal thickness. And I need to see changes in 2 of 3 parameters. I can't answer that because we actually don't, no one yet has a real answer for that. I will say that for progression, and it doesn't apply to the U.S. because most of us still don't have cross-linking, changes on thickness and changes on posterior surface, if I see changes, even though the anterior surface is still normal, to me that's progression. And particularly in a young patient, that's when I really would want to intervene with cross-linking. So if you preserve good quality vision, waiting until you see changes on the anterior surface and then progression is basically waiting until they already had degradation in vision. So I look at both anterior, posterior, and corneal thickness, and I like to see changes in 2 of the 3 for true progression. But if I had a young patient that clearly had a posterior ectasia, a change in any 1 to me would be adequate.
Thank you. Last question for the evening is, how do you measure lenticular opacity?
If you look at, and I don't have it in front of me, The Pentacam does give you the ability to do that. When you look at the Scheimpflug map, if you look at the far right of it, there's tracings which actually represent light transmissibility. And you can do it numerically. It's not something I actually don't do routine cataract surgery, so I'm probably the wrong person to ask that. But as far as that goes, if you look at those tracings, you will see, and you can actually follow a progression of lens changes. The problem is that you got to make sure you're on the same orientation. I don't know if there's a global reading yet on the Pentacam for lens clarity. That I really can't answer. And with that, I'd like to thank all of you in attendance and appreciate you coming on.
Yes. Dr. Belin, thank you on behalf of Oculus and the attendees. We thank you very much for your time and the educational opportunity you have shared with us.
Thank you.
We look forward to working with you again in the near future.
Take care, everybody.
Thank you. Ladies and gentlemen, thank you very much for attending another great educational webinar by Oculus and by Dr. Michael Belin. Please keep watching our emails and Oculus website for other educational webinars on different instruments and topics. This webinar has been recorded and will be posted on the Oculus website very soon. The Oculus website is www.oculususa.com. Thank you very much and have a good day.